Hi, welcome to Introduction to Maternity. This is Unit 7 of Nursing 135. This is your first specialty area. After this, you'll go into mental health and peds. So everything you've done up until now is sort of your basic adult med-surg kind of nursing. So now we're talking about specialty areas. If you look in your outline, you'll see that there are 7 objectives. Some of them are sort of far afield of what we need to do, so I'm not going to list them, but I will tell you what we're going to talk about. We'll talk a little bit about why maternity is something you want to learn about as a pre-licensure area, even if you don't intend to go into it after you graduate. We'll talk a little bit about the agencies that set the standards for this profession, for this specialty within the profession. We'll talk about maternity as a family-centered area of nursing. When you take care of a pregnant patient, you aren't just taking care of a mother with physical needs or a newborn with physical needs. You are looking at the entire family unit. The childbearing process is a milestone. It is a lifetime event. It is honored in extended families and in cultures everywhere in the world. So really, for the best outcomes, we need to consider the whole family and the social situation. We'll also talk a little bit about the public health goals that are set forth by Healthy People 2020. These are national initiatives that are meant to improve outcomes for mothers and babies, and why it's important to consider pregnancy and childbearing and infancy as something that affects the health of a nation. So we'll get started. So moving on with our content. There are probably a lot of people who wonder why, didn't mean to shout. Why do we study maternity in a pre-licensure program? I just want to get to NCLEX. I don't want to be an OB nurse. I don't want to be a midwife. I want to work in the emergency room, or maybe I want to work in psych, or I want to work in wound care. I want to work anywhere, but definitely not that. Some of you might be thinking, well, yeah, I definitely want to study maternity. This is the thing I've been waiting for. It's the whole reason I went into nursing. But there are some really good, solid reasons for why we study maternal newborn content, along with other specialty areas in our entry-level programs. And just to give you a few good reasons, I'm going to quote from the Association for Women's Health and Obstetric and Neonatal Nursing, which is the agency that sort of guides practice for maternity as a specialty. And they've come out with a position statement on nursing education. So I'm just going to read that statement, or an excerpt from that statement. Maternal and newborn nursing education is necessary for entry-level competency. Entry-level is you guys. Childbirth is the primary reason for hospitalization in the United States. And they have cited an article for that. If you're really interested, I can give it to you. The majority of women in the United States become pregnant at some point in their lives, and providing high-quality, safe care for these women and their families before, during, and after pregnancy is crucial to the overall health of the nation. And that statement is echoed by some of the goals of the Healthy People 2020, which we'll also discuss. So try to remember that. Further, women of childbearing age, pregnant women, breastfeeding mothers, and newborns routinely require care in venues outside of maternal newborn specific areas. Such settings include emergency rooms, med-surg units, psychiatric care environments, operating rooms, ambulatory care units, and community or public health-based venues. Registered nurses who do not work in the perinatal setting, but who provide care for women elsewhere, should be aware of the implications that diseases, physical and psychosocial trauma, medications, and other medical surgical management can have on women of childbearing age and on the health of a fetus or newborn. Because women and newborns receive care in various settings, all nurses need at least basic didactic and clinical preparation in maternal and newborn nursing to appropriately care for them. So that's the AWON position statement, and it is more or less true. Most women do become pregnant. It's a major lifetime event. They don't all end up in maternity. Some of them end up in the ER. Some of them might end up on a mental health unit. We've had patients that had to go to the ICU because they needed more intensive airway management than we could provide. So we should really discuss the Healthy People 2020 reasons to study maternal newborn content. Healthy People 2020, just so you know, represent the nation's goals for health of all people. So why do they think that maternal child health is important? Their statement, and I will give you links to all this information, is that improving the well-being of mothers, infants, and children is an important public health goal for the United States. Their well-being determines the health of the next generation and can help predict future public health challenges for families, communities, and the healthcare system. So there's really a lot invested from the Public Health Agency of the United States in maternal, infant, and child health. And it's coming up in the literature a lot that many of the diseases that are major health problems in the United States, like hypertension, heart disease, diabetes, some mental health disorders, really sort of surface their big red flags in pregnancy. And that's a really good time to catch people because this is a time when women will enter the health system voluntarily. They are more receptive to teaching because they want to have a healthy family. For example, preeclampsia a lot of times can warn us that there's some sort of endothelial dysfunction that could relate later to coronary artery disease. Gestational diabetes. About 50% of people, and the number changes depending on which study that you look at and how long they follow people, but eventually about 50% of women with gestational diabetes will go on to develop type 2 diabetes. And this is a good time to get them in and talk to them about diet and exercise and weight control. Depression, sometimes when we see postpartum depression, we're really looking at mood disorders, tobacco use, alcohol use, any kind of substance abuse. We can talk to people about their nutrition. We can talk to people about their weight. So these are some reasons that it's really important to understand maternity and to invest yourself into maternal child health. And the last reason I'm going to mention why we study maternity nursing, and it's what you all are probably most interested in at this point in your careers, is that NCLEX figures about 6 to 12% of their content on maternity. And just so you know that 6 to 12% generally focuses on the health, promotion, and maintenance aspects of maternity nursing. So that's sort of where our focus is going to be for this entire rotation. So if you look at your outline, one of the major objectives that we are going to discuss are the trends and issues in maternal child health. And we're really just going to do a very sketchy sort of overview. And I really want to focus the discussion more or less on Healthy People initiatives. So Healthy People is the agenda that the United States has for the health of the nation. It comes out every 10 years. It has certain goals that kind of cover risk reduction, health promotion, and maintenance in every aspect of health, more or less. You'll find information on quitting smoking and seatbelt safety and autism and all kinds of things in the Healthy People Initiative. But we're really interested in the goals that are specific to maternal child health. So we can kind of get started on that. I really don't want you to memorize the goals or anything like that. I just want you to get a good broad sense of what we really need to consider as important, because they kind of color a lot of how we view prenatal care, how we educate our patients, how we follow up with them, how we maybe follow them through the lifespan. So Healthy People has its number one goal of reduction of fetal and infant mortality. And I know most of you are well-read people. You know that the United States has an appalling rate of infant mortality compared to other developed nations. And part of that is because we have very large disparities between different groups of people based on their socioeconomic status. And so Healthy People tries to resolve that. And one of the ways they do that is to target different segments of the population for funding or for educational programs. But underneath that initiative are a number of sub-initiatives that we aren't going to talk about. in great detail until we get a little further along. But just so you know that they're trying to reduce that infant mortality and make us sort of more on a level with nations that have a better record of outcomes. They also try to reduce maternal mortality. And it's still sort of shocking to me that in this country, where there are hospitals that are equipped with all the right equipment, all the right medications, they have, healthy blood banks, that we still see women die. And I think some of that, a lot of it, really, according to the literature, is about failure to rescue, especially when it comes to things like postpartum hemorrhage and eclampsia, which are the two major causes of maternal mortality, postpartum hemorrhage being the first of those. We have this bias that it's all healthy and it's all fine and it's all good, and when you start to see a patient deteriorate, you almost don't want to believe it because they're 28 years old or they're healthy women who came in to have a baby with usually no other risk factors. And so when they do the chart reviews for these women that died, they see a trend towards, maybe the vital signs were really deteriorating and nobody really did anything about it because, again, they're healthy, they're young, they're going to be fine. So one of the projects that Healthy People 2020 and AWHONN are working on are ways to reduce maternal mortality. AWHONN just completed a postpartum hemorrhage project, which was really to reduce the risk for women. Again, because we don't want to just ignore the symbols and we don't want to fail to rescue somebody who's in trouble. One of the things that came out of this project was the knowledge that for every maternal death, there were maybe 50 women who didn't die but needed extensive recovery from a postpartum hemorrhage. Maybe they needed massive transfusion, or maybe they needed some kind of surgical procedure. And so one of the other goals of Healthy People is to reduce complications. Excuse me. Oh my goodness, my typing is terrible. Due to pregnancy and maternal illness. And so there are a number of initiatives that deal with that. They want to reduce cesarean birth in low-risk women. There's certainly a place for cesarean birth, and the World Health Organization basically tells us that if you are doing fewer than 5% of your births as cesarean sections, you probably have issues with access to care because, a certain segment of the population needs to deliver by that method to get a good outcome for mother and baby. However, if you're doing more than 15% of your births as cesarean sections, most likely you're doing unnecessary ones. And so, and they do cause complications. Cesarean birth is a lot like any other surgical procedure. You can have wound infections, you can have bleeding, you can have dehiscence, you can have DVT, you can have atelectasis, you can have paralytic ileus, just like any other surgical procedure. Additionally, it creates problems in subsequent pregnancies. You can have abnormalities of placentation, which is the process of the placental development or attachment, and you can have uterine rupture. And so we want to reduce the cesarean birth rate in America. Okay, so one more. We're not going to do too much more with Healthy People, but I would like to talk about one of their other major initiatives, and it is the reduction of low birth weight infants, very low birth weight infants, and preterm birth. And all of these things sort of go back to the first thing, the reduction of fetal and infant mortality. Because low birth weight and preterm birth, a lot of times these are things that impact your infant mortality and also the rates of disability and morbidity. And this is sort of where we see our biggest disparities. Infant mortality, preterm delivery, much higher incidence in certain socioeconomic groups, and the biggest disparities with African American women. They have almost double the rate that other ethnic groups have for preterm delivery and low birth weight infants. When you guys do your project for March of Dimes, Trenton has a very high rate of preterm delivery. It's how we got the level 3 NICU, when we were at Mercer. And that level 3 NICU is now at Hopewell, which is outside the city limits, but still services the population of Trenton. So there are a number of initiatives that deal with that. And while we're talking about health disparities, Healthy People has an additional goal of increasing access to care for all Americans. In fact, they have a very, very ambitious goal of 100% access to care. And the Affordable Care Act does sort of make it a little bit easier, but there are some segments of the population that still have difficulty accessing care. And so that's a goal that Healthy People would like to work on. Prenatal care really is sort of the biggest indicator of your outcomes. If you have good prenatal care, chances are, even though childbearing is, considered a wellness process and not an illness, you still need to seek the assistance of a healthcare provider for the best outcomes. So one of the bigger trends and issues in maternal child health is the emphasis on evidence-based practice. When I started nursing, a lot of OB was still fairly tradition-based. There were things that we did because they worked for us, or that's the way they were always done. But over the last 14 years, there's been a real explosion of information and a lot of really good quality research that has changed our practice. And it seems like there's something new every time I go into work. And it's pretty exciting. I think that for the most part, we are all embracing these changes. You'll hear people say that the push for evidence-based practice in maternity is litigation-based. A lot of people do feel that there's too much litigation in OB. But really, I think it's outcomes-based. I think we all really want the same thing. We want healthy moms and healthy babies. And so it's fairly exciting that there's so much more evidence and better practices out there. And two organizations that guide our practice and sort of help us choose policies and guidelines based on the evidence are AWHONN, which I've already mentioned. That's the Association for Women's Health and Obstetric and Neonatal Nurses. You'll hear a lot of reference to that. They've published a lot of fetal monitoring guidelines. They talk about different health initiatives, perinatal mood disorders, breastfeeding. They do a lot of they sponsor a lot of good quality research, and they publish it in the Journal of OB and Gynecological and Neonatal Nurses, which is JOGNN, JOGNN. I'll bring some of those issues in, and maybe you can kind of see what I'm talking about. The other main organization is more for obstetricians and gynecologists, and that's the, American Congress of Obstetrics and Gynecology. Used to be the American College of Obstetrics and Gynecology. They changed the name a few years ago to reflect their mission on changing health policy. And I'll spell that one out for you too. So periodically when we talk about the treatment guidelines for various disorders, I'll reference one or both of these organizations. Let me just get all those words in there. Oops. Oh, excuse my typing again. Okay, so those are our organizations, the major ones. There are private organizations. You'll hear reference to things like the March of Dimes, and you'll have a presentation by them too. There are lots of organizations that attempt to create better outcomes for moms and babies. So that is one of the bigger issues. So one of the other big issues, and I kind of touched on it a second ago when we talked about outcomes, is the fact that your textbook goes into a lot of detail about the legal implications of obstetric practice and nursing. And I don't want you to come away with the idea that everything we do is driven by that. It's not. Again, I feel that we are outcomes-based. But when there is a medical error or when there's a bad outcome in obstetric nursing, it is a tragic, terrible thing. Nobody expects when they go into the hospital to have a baby, which is a routine life event, big milestone, that they're going to lose a mother or lose a baby or have a serious disability or serious injury. And that's where some of that fear philosophy comes from. But according to the Joint Commission in 2010, about 72% of adverse events in the obstetric setting, sorry if I'm, writing while I speak, could be prevented by better communication. And I want you to think back to that S-bar exercise we did on our first day of lab. I'd like to at some point revisit that S-bar exercise and give you guys some real clinical scenarios to work with. Because if you can communicate what you see effectively, you can get some kind of action usually out of a provider. If you can't, you can go up the chain of command. But I would say that the vast majority of things that go wrong are either that somebody didn't interpret what they were seeing correctly, or they didn't report it to the right person in the right way. And as a freshman level student, you don't get a whole lot of practice giving S-bar to providers, so we are going to role play that at some point during this rotation and get you all sort of better at that interprofessional communication. Communication and collaboration are key to better outcomes in maternity. Really, and most times, for every adverse event that we see where something went horribly wrong because things weren't communicated, I can tell you that on a routine daily basis, things don't go wrong because we do communicate and we do collaborate. So that is sort of one of the issues that I would like you to focus your attention on. So our last topic for today is family-centered care in maternity, and maternity is a family-centered specialty. Even though many of our daily tasks on the unit might be centered around physically caring for a laboring mom or a postpartum mom or a newborn or doing fetal assessment of one kind or another, we really have to take the focus that we are caring for the entire family. When these folks go home with their newborn, or even without if the baby stays in NICU, they have to reorganize everything they do around this new child, even if it's not their first. It is easier typically when you have more than one. But our actions really have to include everybody in that family, the father. Sometimes grandparents are very present and involved. So there are all different types of families. We define a family, according to your book, as a group of individuals related by blood, marriage, or mutual goals, a sense of belonging, passion for being involved in one another's lives. And I'm not typing that out because you don't need to memorize it. It's just a rough definition of what a family is. People define family either based on blood or marriage. Some people will say that, so-and-so is like a sister to me. And so that is, sort of a family of choice. Families can be roughly categorized as traditional or non-traditional. Although I think our traditional idea of what a family is has changed a great deal over the last, 20 or 30 years. Your book talks about all the different types. The nuclear family, which is mom, dad, and kids. Extended family, which includes grandparents, cousins, aunts, uncles. Single-parent families, dyad families. You really don't need to memorize all of these. You need to have a respect for the differences between what you may consider to be a normal family and what someone else does. And I will tell you that over the last 14 years, I've seen a trend. It seems to be higher almost every year, that most parents, especially the younger ones, are coming in now and they're not necessarily married. And I also saw a trend for a little while, which is kind of interesting, of very young nurses who had very sheltered lives, and they wanted to have social service consults on everybody. Well, this one's 19 and she's not married. Well, yeah, but she's got a lot of family support. You have to kind of look at whether this family is really at risk and not assume that they are based on whatever label. I've seen a bigger trend towards gay and lesbian families. On the maternity unit, you won't see as many gay men unless they have a surrogate. But you will see a growing number of lesbian families because usually one of the partners is carrying the child and giving birth. You may be present for adoption on the maternity unit. So you have to have a very broad sense of what a family is and be able to support all these different types of families. You know, I remember one of the first times that I saw a birth with a student, and it was nothing for me. I had worked on the unit for a long time. The girl was about 19, and the father of the baby looked about the same age. And the girl's mother, the baby's grandmother, was very actively participating in the labor and the delivery experience, and the father of the baby had sort of hung off to the side. And I made sure that we included him with the baby care and the baby bath so that his role could be honored. But when it came time to put the bracelet on, and the bracelet sort of designates who the primary support person is and who has access to the baby, whether the baby's in nursery or NICU or with the mom, I asked the mom, who do you want? And she said, my mom, without hesitation, and the student was floored. Well, why wouldn't you just give it to the father of the baby? Well, because that's not how their family worked. You know, we were very inclusive of the father and his role, but in that family, that maternal grandmother was the person that the mom looked to for support. So we had to honor that as well. Okay, so in continuing the topic of families, we're going to consider families in the context of culture. Because families don't exist in a vacuum. They're embedded in neighborhoods, they're embedded in churches, they live in the community, and they also are the carriers of their culture. If you think about it, the way that a culture remains intact is that within our families, in our communities, we're taught all the values and practices of our cultures. And so the childbearing process, pregnancy, delivery, the infant period, parenting children, all is of great interest within a culture. And a lot of cultural practices sort of sprout out around that. Those practices can be grouped loosely into three categories. There are prescriptive practices, and by that I mean what mom must do. She has to do these things to have a healthy baby. For example, mom needs to eat meat in order to make a healthy baby, so that her blood is nice and strong. Or mom should wear certain necklaces or bracelets or articles of clothing, or mom needs to go to church at this time or that time. Those are prescriptive practices. There are things that the mother must do to ensure a healthy baby. Then there are restrictive practices, and these are what mom shouldn't do. For example, mom shouldn't reach over her head, or the cord will wrap around the baby's neck. Or you shouldn't have a baby shower, because if the baby doesn't survive, you know, it's sort of a jinx or something like that. Or you should avoid weddings or funerals or any number of things that you should not do. So that is a restrictive practice. A taboo practice is similar to a restrictive practice, and it is an action that has severe supernatural consequences. Forgive me while I talk and type at the same time sometimes. It's hard for me to walk and chew gum. Things like don't go out in the moonlight, or your baby will have a deformity, or don't compliment your baby, or somebody will give the baby the evil eye. You know, don't have your picture taken, or you'll have a stillbirth. Those are the kinds of things that fall under the umbrella of taboo. And, you know, when you're dealing with culture, you have to remember not to stereotype. Not every individual from every culture will follow every practice. You need to assess culture in the context of that individual, but you do need to incorporate anything that the mother thinks is important or the family thinks is important. You are incorporating. So that is about as much as we're going to cover in this unit. And we'll talk in class a little bit more about all of these concepts before we move on to antepartum nursing and then intrapartum nursing. Then we'll do some high-risk intrapartum before you move on to postpartum and newborn. But
Good luck throughout the rotation, and see you in class.